Today's our esteemed speaker, Dr. Sunil Paudel sir. He is the first PNYS registered, licensed practitioner in UK and Nepal. He has done PG diploma in pain medicine from Cardiff University, UK. He has also done fellowship in pain and spine from USA. He is also a McKenzie Institute certified practitioner from USA. He is PhD in spine from Malaysia certified. He's also certified in kinesiology, taping, aqua fitness, sports injury from USA. He is also reviewer to Journal of Orthopedic Science and Research. He is chairman to Spark International Health Resort, Kathmandu. He is founder director of Prana Spa USA and Spark Hospitals, Nepal. He has almost 24 plus years of excellence in spine, pain radiculopathy, joint pain, and stroke rehabilitation. He has trained more than 1,500 doctors globally. He is a globally recognized authority in non-surgical spine management. We are privileged to learn from a visionary whose clinical expertise, academic leadership, and international training have shaped modern rehabilitation practices. Thanks for joining us. With that, I offer the stage to Dr. Paudel sir for presenting today's workshop. Meanwhile, requesting
Chetan Sharma.
Chetan.
Chetan, bolo.
Thank you, Dr. Vivek Bhartiya, and thank you everyone for joining me. Shall we wait or shall we begin?
I think we can start.
Okay.
We may have people joining.
Okay. Is my screen visible to everyone?
Yes, sir, it is visible.
Okay. So let's begin with some question. So this is about radiology. Okay. So there are 2 boys and 1 girl. 1, 2, and 3. Let's begin with a joke. Okay. So please find out the girl.
Sir, middle wali, second number.
Okay. Sachin is saying middle wali. Is there anyone? Any other opinion than that? Everyone agrees to the middle one? Maybe she doesn't want to listen to everyone. She doesn't want to listen to anyone. Okay. Okay. Okay, so I love this proverb. A disease known is half cured. Okay. So many a times I've seen people, maybe I used to do the same 30 or 25 years back. A disease known is half cured. We used to treat diseases without knowing the precise diagnosis. In many kinds of diseases, that's all right. But when it comes to spine, many a times we need to be very precise. So, spinal diagnosis is all about diagnosing it before treating it. Okay, you can treat pain, but not the condition or not the underlying cause. So for that, we need to sharpen our skills. And in this field of, let's say, complementary and alternative medicine, naturopathy, Ayurveda, physiotherapy, I've worked with lots of orthopedics and neurologists as well. Even many a times in beginning phase of your practice, it will be very difficult for every clinician to know everything. Okay, so we've been trying to educate people about how to diagnose and how to treat spinal conditions conservatively. So I just wanted to show you this, that before treating anyone we need to precisely diagnose. So let me quickly change the setting. And share you again. Let's begin with this gentleman. Okay, so this gentleman visited our clinic few days back with severe pain, and he used to work abroad. He came back home because of pain, and they started treating him, but him having treatments for 1.5 months, they were not he was not getting results at all. Okay, so as we all know, these are the few exercises. Is the screen visible to everyone? So this
Yes,
is,
sir. It is
yeah,
visible.
that's what we are taught. Okay, I don't know who started this trend, but the moment back pain, we think about extension exercises. Okay, Sarpasana, Bhujangasana, okay, Ardha Chandrasana, all these things. Extension, extension, extension. And his pain was also very non-specific. He used to get pain with lots of activities, mainly while walking, while working, prolonged activities, all these things. So they gave him extension exercises. Okay, and they also gave him katibasti. Okay, lots of people practice this, and so these were the few things that stood out to me, led to the failure of treatments. Okay, so let's go to his MRI. I hope MRI is visible. We can see at L4, this is L4, and this is L5, this is T2 sagittal image. So in between L4 and 5, you can see there is disc herniation, and it has the central canal, the spinal canal is involved. And if you see the reports, there were tons of things you won't believe it was written. And now I'm showing you T2 axial image. Okay, so this is L45. I will zoom in. That's my finger showing it. So this is L45 disc. As you can see, there is there is crowding of cauda equina nerve roots over here, and this is pure posterocentral disc herniation. Okay, this anterior part, this is posterior part, this is pure posterocentral disc herniation, and you can see there is crowding of cauda equina nerves, and probably both of the traversing nerve roots are compressed over here, though exiting nerve root which lie over here are not compressed. Okay, so let's go back. So what was the mistake? Extension exercise, of course, was the mistake. Why? Because as we can see, when there is pure posterocentral disc herniation and there is spinal stenosis, it might be very difficult to treat with extension exercises. So it won't be written in radiologist report. The radiologist report will lack such insights which enables you to come to a definite conclusion which exercise to give, which treatment to give. So in this kind of posterocentral disc herniation, all extension exercises, whether it is standing or lying down, will lead to the disc herniation more posterocentrally. Okay, in almost more than 95% of the cases with extension, it is going to get worsen. Okay, and that's what they've been practicing. Okay, extension exercises, and then giving katibasti and massages in prone position. Now what happens? Prone position is a kind of hyperextension in itself, because the belly goes down, the spine goes down, it will be easier to give, but this is also extension. Those were 2 points that stood out immediately, and I changed the protocol. I asked him, never have any treatments in prone position, never do any extension exercises, just with the help of this MRI. And after a few days he started feeling better immediately. Okay, so we relying on radiologist report is not going to help us at all. We need to rely on our own discretion. We need to amalgamate radiologist report with our own insights, because we practice vast science. Our science is like jack of all kind. Okay, so this was first case. Let us quickly go to another case. Okay, so let me share the screen again. I didn't have time to prepare a slide, so that's the reason I'll keep on disturbing you. So the only solution I have got is closing and going again. Is the screen visible? Do you see a case sheet?
No, sir.
Okay.
No, sir.
Okay, let me quickly close this down and I'll go back again. Here we go. Okay, can you see it now?
Yes, sir.
Okay, so
Yes,
this
sir.
now I think you can kindly pin on to the screen where a case sheet is visible. Okay, so this is a case of a lady who is 68 years old and who is housewife, slightly overweight, who came to see us with lumbar spondylosis with bilateral sciatica. Okay, I'm not going in depth, so just quickly showing you. And this is her x-ray, so we can see lumbar spondylosis. Let me slightly zoom in. Okay, so we can see lumbar spondylosis with osteopenia, right, and slight scoliosis. Nothing, no great finding on it. So but she had got now what I would like you to note down, that disc space are well preserved in every disc. You see L5S1 is triangular as it should be, slightly triangular, and then all disc space are well preserved. Outline of the bone is not beautiful because of osteopenia. You cannot see bone mass, that's because of osteopenia. If you go for DEXA scan in such cases, you could find out whether this is real osteopenia or osteoporosis. So we had one MRI done, and basically as there was no disc space reduced, my colleagues started treating it conservatively. They treated her for almost 30 days, and after 30 days she did not get the results she was looking for. So then she came for me. The moment I did her physical examination, I asked her to go for an MRI, and this is the result of MRI. Okay, now you can see at L3 and 4 there is spinal, the spinal canal is compromised, and at L4 and 5 also the spinal canal is compromised. So you can see lots of visceral fat as well as subcutaneous fat. You saw, I told you already, she was slightly overweight. Now if you know radiology, if you are one of my students, you can easily find out. So it is not a case of only disc herniation. Okay, it is not a case of only disc herniation. There is at the back, this is epidural fat. If you can see my cursor, this epidural fat, and this structure, this black dark structure behind, are called, can anyone tell me what these structures are? Right at the pointer. Please unmute and speak up, please. No one? So can you see this structure as well? It is there in every segment of the spine. So this black structure right over here, this black structure, and this structure, these are all the same. Okay, these are called ligamentum flavi. Okay, so this is the normal ligamentum flavi that you can see, the normal ligamentum flavi outlines. This is slightly hypertrophied and this is totally hypertrophied. Okay, now over here you can see ligamentum flavi is totally hypertrophied, and this is the central canal, and central canal is totally obliterated, not only because of anterior elements, that is called disc herniation, but also severely hypertrophied ligamentum flavi. Okay, so this was T2 sagittal image. Now this is T2 axial image. So let me quickly show you what is normal and what is not normal over here. This T1 axial. So let's go to T2. This is coronal, showing slightly sacroiliitis over here. Still confusing to everyone. Now this is T2 axial image. So let's go over here. So this is how it should be. The central canal should be something like this. Okay, so can you see my cursor? The central canal should be something like this. Okay, this is normal central canal, though this is vertebral end plates. This is how normal disc should be. Disc outline should be something like this. This neural foramina are slightly obliterated, but over here central canal should be something like that. It should be, in females it should be around 15 mm in anterior posterior diameter. Now this is slightly obliterated central canal, slightly stenosed. Now over here, as you can see, now I'll zoom in and I'll show you. You can see, you can hardly see the central canal. Okay, now the disc herniation is grade 1. Okay, disc herniation is grade 1, ABC, you can say. This is Michigan State University MSU classification. So but the central canal, the cause of spinal stenosis is not because of the disc herniation as such, because it is grade 1 ABC, but because of the severely hypertrophied ligamentum flavi. How it should have been? It is also slightly in this segment also, you can see it is slightly hypertrophied. This segment also slightly hypertrophied. in any normal, you should see just a faint line. Okay, right over here in this, you can see this faint line. This is how it should be, it should have been. But now over here, that ligament is totally hypertrophied, and because of that, it is getting compressed posterior to anterior. And after practicing spine for more than 24 years, I really don't know any treatment available for working on this hypertrophied ligaments. So that was the reason she could not get any results. And as you can see, there is hardly 2 mm or 3 mm of spinal canal remaining. So that was the reason for spinal stenosis and neuroclaudication. She could not walk at all. And in such cases, no matter how much you try, it is very difficult to get results. It might take sometimes years to get some results, but it is hard to convince the patient for years, mainly for newer practitioners. I could convince for tens of years, but it will be very difficult for any newer practitioner to convince, no, she's going to get all right, because you cannot explain the patient at all. Okay, that was the reason she was not getting any results, and usually conservative management doesn't help in such cases at all. Okay, I'll stop over here. And to understand such things, we started the fellowship courses. Okay, because we that will uh, give you basics of understanding spine, and basics how you can treat and give results. You need to be very very selective while selecting the patients. You need to be very very selective. So that is why we started this course fast. Okay, fellowship in advanced spinal techniques. That was the reason we started this course. Now we have got almost 1500 graduates who have done some kind of spinal course with us. Let's see. Kindly note down your questions. We'll deal that later. I'd like to finish few more cases before we come to question and answer. Okay. Let's go to another case. Okay, I hope this X-ray is visible to everyone. If not, kindly pin it over there. Is the X-ray visible to everyone?
Yes, sir.
Okay.
Visible, sir.
Yeah. So you can see this is C1, C2, C3, C4, C5, 6, 7, and you can see diminished disc space because of severe osteopenia. You cannot see C4 clearly, but over here you can see C4 clearly in AP view. In lateral view it is difficult, and this was being treated by some, I mean, he is a good famous Ayurvedic doctor. And then okay, then he, just to make sure he is good, uh, the patient is good, whether there is any some problem, he went for an MRI, and MRI revealed 1 2 3 4, there is C4, there is some lytic lesion. But unfortunately people get carried away. The moment if someone comes with neck pain, you tend to give what's your first line of treatment? Can anyone speak up? Okay, in naturopathy, in Ayurveda, the first line of treatment, you tend to write massage. Okay, so he precisely wrote massage. He was good. He had got like 15 years of experience under his belt. So he gave massage. Maybe he explained the massage therapist or not, how to give massage or where to give massage. So can you, if we zoom in, right, you can see the spinal cord is intact, slightly indented over here by C4, but no big lesion. So the patient also had got some radiculopathy. So naturally, for radiculopathy and neck pain, massage is fantastic. So he just wrote massage and sent. Okay. So this is previous treatment. After treatment, the patient came to me with severe pain, okay, severe radiculopathy, and the patient came to me with quadriparesis. The patient's both upper limbs and lower limbs were paralyzed totally after massage. So I immediately asked the patient to go for an X-ray. Okay, this is the X-ray I found. This is AP view. This is lateral view. Can you see in lateral view? Okay, now the alignment is totally gone. It has gone into reverse curvature. You cannot see the body of C4 vertebra at all. Okay, 1, 2 and 3 are okay, 5, 6 and 7 are also okay, but now over here you can see subluxation. Okay, I did not treat the patient. I immediately asked the patient to go for an MRI. Now this is the MRI report I got. Right now you can see the C4 body has gone into retropulsion. Retropulsion, that's called posterior propulsion of the vertebral body into the spinal cord, and spinal cord is totally obliterated, totally damaged, led to myelopathy, immediate myelopathy, and patient never recovered in his life. Right now you can see this retropulsion, a fragment of the vertebral body has gone into the central canal and obliterated the central canal. Okay, so rather than treating such cases, if you don't know radiology, you tend to do mistakes. Okay, this is not treatment. Basically the patient lived, right? But I wish, if I was the patient, I would wish to die rather than have quadriparesis for rest of my life, just because lack of clinical judgment, lack of knowledge of spine. So this is one of the horrendous case I have ever seen, one of the horrendous mistakes I have ever seen done by complementary health practitioner. Let's go to another case. Now kindly note down your questions if any. We'll discuss that later. Okay. Okay, I'd like to share another case series. Another case of mine. And this is one of the case. Patient was seen by two specialists, and sent to therapy. From higher center, they sent for therapy. Okay, so a few findings I'd like you to note down. This was his X-ray. A very young man. This was his X-ray. Uh, Unremarkable as such. Okay, there might be slight sacroiliitis on left side, otherwise totally unremarkable. No need to worry. Usually my colleagues, my juniors, see the patient before I get patients, because I've got my own bulk of patients which I cannot finish in a day. So this was his anteroposterior X-ray. 5, 4, 3, 2, 1. Perfectly all right. Good alignment in AP view. No congenital defects as such seen in this AP view. Now over this lateral view, you can see loss of lumbar lordosis. This is totally straight. Okay, but disc space are well preserved. Bone densities are fantastic, so I did not worry about that. So the MRI was already done by specialists, orthopedic and neurosurgeons, and as you can see, there is slight disc bulge. This is T2 sagittal view. So as you can see, there is slight disc bulge at L45, small node, L45, L34, L45, and L5S1, and we can see more spinal stenosis at L4, L5S1. Okay, and this is posterocentral. As you can see, there is nothing on lateral, other lateral sections. Let's go. And this was the MRI report. This is one of the best centers. Bir Hospital is one of the best centers, best medical colleges, government medical colleges. And you can see report, just common report, nothing so much exciting or something like that. Okay, so common report. All my students can write such reports without any problem. So increased back pain since 20 days, left side, difficult in walking 20 days. He could not turn over, he could sleep in only one side. Okay, he had got deep vein thrombosis on left leg, chronic deep vein thrombosis, and he was on rivaroxaban, okay, 15 mg alternate days. And they started giving in treatments, and the pain increased like hell. They admitted and gave treatments, and the pain increased like hell. And 1, 2, 3, by third day he could not sleep, he could not move, and I had to intervene. On third day I immediately stopped moist it, I mean any heat packs. I gave ice revulsive compress. Ultrasonic therapy was okay. I cut off all the massages, all heating therapies immediately that day. Okay, and I went and saw the patient. I examined, and I was not happy with whatever I saw. Okay, the patient sign and symptoms and physical examination did not suggest the lesion that was present in the current MRI. And usually I hold one authority, and basically I never believe in any specialist, I never believe in any radiologist report. Okay, so as I was not happy, there is different protocol for each and every of my patients. Okay, I do MRI differently for each and every patients. So as I was not happy with this, okay, and this was just LS spine with the screening of SI joints. I was not happy with the reports. I did detailed physical examination. Then I sent the patient for MRI. Okay, only T2 screening sagittal was done, so I referred to the same center to give me coronal and axial images as well. Okay, and then the radiographer got angry and gave not only those sections which I was asking for, he gave every sections, and this is what we found. Okay, let me quickly zoom in over here. Okay, you need specialist view, specialist eye. So this is T2 axial image. Now these are the paraspinal muscles. This is the central canal, slight disc herniation. Now you can see this is the right psoas muscle, and this is left psoas muscle. Now in left psoas muscle, can you see lots of exudate over here, lots of collection, and this collection has gone into the paraspinal muscle, and without knowing that, we had been giving massages just based on MRI reports, and as it was referred by specialists, we can do anything. Okay, so no, that's not the case. So if you can see other sections, you can see the same lesion on the left psoas muscle and paraspinal muscle. Okay, same lesion in every section. So it was, then I took over, I saw the reports. Now this is coronal image. Okay, now in coronal image as well, these are the psoas muscle. Okay, right psoas muscle, this is left psoas muscle. you can see the lesion, something like this. The way it looks, it must be some infection and collection over there. And so I asked the radiologist to give me extensive report, and left psoas collection was the diagnosis. And we had all the sections. We did contrast MRI. Okay, then the patient revealed that he had DVT because of drug abuse. He used to have injections all the time. Okay, and because of that he might have got infection, and that could have been the cause, and he was referred to the surgeon for culture sensitivity and all the treatments, surgery, draining of the abscess, and he became all right. So many a times, without knowing, just relying on whatever is in front of you without utilizing your knowledge, it will be very difficult to treat cases. Now let me quickly go back. Another case. I hope it is not monotonous.
It is interesting, sir.
Okay, good. At least for few people. Okay. Many a times I get cases that are like that are ruined, and they come to me at last, and it is very difficult to treat them. They think it is just therapy is therapy. They can go anywhere, do some therapy, and get cured. Many times it's okay. 90% of the cases it goes okay, because if you just give few pain management treatments like massages, TENS, ultrasonic, some heat, it goes all right. But sometimes it doesn't. Right? In few cases it doesn't. Okay, let's see another case. Okay, so let's focus on this case. This case of you can see this is T2 sagittal image. You can see with the by having a look at subcutaneous tissue, he must be little bit overweight. Now there is complete loss of cervical lordosis. Basically, there is cervical kyphosis, what we call reverse curvature, right? Cervical spondylosis, some disc herniation is there. This is his case sheet. Okay, this is the patient. And now after this was before treatment, and after giving treatment it worsened. Now what worsened over here? You can see the cervical reverse curvature has even worsened. And if you have missed, I'll show you a small lesion over here. If you are a nice clinician, you can see 1 2 3 4 5 6, in between 5 and 6 disc herniation. You can see subtle hyperintensity, okay, right over here in the spinal cord. If you did not, don't worry. Okay, that's now over here. You can see that hyperintensity has increased a bit, and the cervical lordosis also has worsened. Now in such cases there is no huge lesion, there is no need to do any surgery. Right over here you can see that lesion. There is whitish lesion that is separating spinal cords into two pieces, right? This is what we call myelopathy. Okay, and myelopathy can have devastating consequences. It can lead to weaknesses of one limb, two limbs, all limbs, quadriparesis. Okay, it's almost like almost dangerous like spinal cord injuries. This is a kind of spinal cord injuries, but sometimes it is reversible. So there is hope. So if you don't know the diagnosis, don't treat it. Okay, so the myelopathy was missing in the report, and people kept on treating without any results, and they kept on giving massages, and because of the hard massages it went even worse. Let me show you today's one of the last cases, which is even more interesting. Okay, let's see this gentleman. Okay, I hope you can see the screen. Yes.
Yes, sir.
Okay, so this gentleman came to me with lots of hope that I'm going to get him better. He was walking, but with a very typical gait, which you can see in my channel, Dr. Sunil Paudel, in Facebook, in YouTube, TikTok. I've got a good fan following over there. So this is the CT scan he showed me. Can anyone tell me the diagnosis by just having a look at the CT scan? Anyone? This is very typical, and this is not found in any other diseases than one. Do you need any clue? It is by birth. It is congenital usually. It is congenital. The disease is congenital. Okay. This condition is called ankylosing spondyloarthropathy. What we used to call ankylosing spondylitis. Now, what is ankylosing? Is fusion of all the vertebrae. Can you see? There is no separate vertebrae over here. This is anterior longitudinal ligament, which is totally fused. There is PLL is not fused at all. Now you can see supraspinous ligament is also fused. Now basically we have 26 vertebrae, right? When we get birth with 33 vertebrae. By the time we become adult, we have 26 because the fusion keeps on going. But this gentleman had only one vertebrae because everything from top to down is fused. And he was naturopathy and Ayurvedic treatment lover, so he went to them. Okay, and he used to keep on taking hard massages and Ayurvedic therapies and everything and naturopathy therapies, and then someone with very no knowledge of spine told him, okay, your body is too stiff, let's go for manual therapy. So they start cracking his spine. Okay, do you want to see the result? So this is what it resulted in. Because the spine was only one, now they broke his neck right from here. Can you see my cursor? The neck is broken right over here, right? And his lumbar vertebrae are also broken totally. So this is the result of cracking without any knowledge, manipulation without any knowledge, massage therapy without any knowledge of spine. Now if you see, the neck is broken, and back is also broken at right L4. L3 is broken, L4 is also broken. Total fracture. Now he went for it after his pain started worsening. He went for an MRI. Now you can see this L5, L4, L3. There is L4 is totally fractured, and there is retropulsion, and chorda equina is totally compressed. Now even the posterior elements are also totally into two pieces, and CSF is leaking outside. But this gentleman is still walking. Right? This is what happens when you start treating without knowing anything about spine. So yeah, if you feel it is unsafe, better. So my formula is first do no harm. Okay, it's okay not to give any benefits, but never do any harm. If you are not sure, don't touch that. Okay, so this is the end of today's case series. I try to enlighten you with some of the horrendous mistakes we tend to make without knowing the precise diagnosis, without knowing how to read x-rays, how to read MRI, all this stuff. So my suggestion always will be never treat anyone without uh, knowing the precise diagnosis. That's why I was telling a disease known is half cured. At least you know now what not to do, right? Okay, any questions? Dr. Vivek Bhartiya, are you there? Dr. Vivek Bhartiya was my mentor. He was my immediate senior in SDM CNYS, and I was his roommate, and I owe him a lot. And because of him, it was really difficult studying first year, and I came almost few months late, and he was there to guide me when I was lagging behind in studies, and he was always there when I even had fever or any cold. I remember him beside me all the time. I owe him a lot.
Thank you, Dr. Sunil. And I do remember our hostel days and the college days.
Yeah, we had fun.
So, now some 26 years back, all the experience. It was year 1997, 98.
Yeah.
I think. Well, I hope all the participants they had a excellent learning session today. Especially, see, in naturopathy we need to be more competitive in terms of treatment. It's just not the random treatment one has to do. So we need to understand this basics of medical science to do our practice in a better way, and then to give better results to the patients who are coming to us. That's how that creates more belief in the system, and we are able to help everyone in a very scientific way. So, so we had approach to learn these things in today's session, and now